So when you start with that, when you have a case which is a post-operative status, these are the histories that you need, right? First of all, why the surgery was done. Was the surgery done for a tumor? Was the surgery done for a resection? Was the surgery post-traumatic? Was it for the stability? Was it because of the disc? Right? So grossly mentioning all of these, was it because of the radiculopathy? Was it because of the complete canal stenosis? So these are 4, 5 indications most commonly for which the surgeries are done. The second thing is the type of surgery as I've included in it. Time since surgery. How much time is it, like a recent one? Are they getting a baseline scan after the surgery, or it has been a long time? Maybe a routine follow-up, or whether the patient is symptomatic. So is it an asymptomatic follow-up scan or is it a symptomatic follow-up scan, right? How much time has elapsed since the patient got a surgery? Was there a re-surgery done since the last surgery, right? And if at all the patient is having, please ask for a post-operative scan, post-operative X-ray, which they usually end up taking to look for the alignment apart from the fluoro that they do like an intra-op one. So look for the baseline scan which was done. Most commonly an X-ray should be available. So there are indications why the operation is being done, right? And these are the common indications why the scans are done, which include discogenic pain, nerve root compression. So it could be a radiculopathy. It could be something like a cord equina, which includes the cord equina or a cord compression pattern. It could be post-traumatic leading to instability, cord compression, radiculopathy. It could be a tumor removal, and it could be curve correction like a spondylolisthesis or a scoliosis, which involve like a major stability constructs. And again, the stability part that we have discussed, the stability which has been defined, the grade of the stability that was there, which section has been operated upon. So what is our goal of imaging? So first of all, identifying what is not there, what has been operated, which part of it has been removed, right? The second thing is something which has been repaired and something which has been put into. Something like identifying the hardware, the integrity of the hardware, and the alignment of the hardware. This is something which is very important. It starts as soon as a baseline imaging and shall be done even when the patient is symptomatic or asymptomatic. Then the curvature and the alignment of the spine. So quite a number of times it has been done for curvature abnormalities or because of the instabilities. Either way around, this is something that you need to look upon, whether the curvature and the alignment of the spine is okay. Coming next, stability, like you get like flexion extension views, we also get it post-operatively, and whether the required fusion has been achieved. And not just the affected segment, not just the operated segment. Sometimes the culprit lies in the adjacent segments, the segment above and below it. So these are the things that you need to keep in mind when you are imaging the spine in a post-op status. How to image. Now, what all modalities you have to image it, right? Starting from something which is very basic, but yes, done day in, day out, easiest available, and can be done in a dynamic way, flexion extension views. So baseline, then the dynamic status, flexion extension views, and can be done in a follow-up pattern, which goes like this: 2 weeks, 6 weeks, 3 months, 6 months, and a year. A lot of neurosurgeons follow this pattern. Then CT is very good for hardware integrity. Whether any part has been dislocated, has been fractured, something that CT gives you a better idea as compared to the X-ray. The loosening status and the bone union. So the bone union, the usual time is by 6 to 9 months, something that should be very, very visible on radiograph by 9 months. And if for CT, you have to call it somewhere around 6 to 9 months. So when the fusion has been there by 6 to 9 months, then it is considered to be a normal outcome that has been expected out of the fusion. Then myelography. Myelography is not something that has been usually done, that is usually done, but it gives you an edge when you are particularly imaging it for the facets and for the facetal and for the foraminal narrowing. For that particular aspect, CT myelography, yes, does very well. MRI, obviously, we know it is for soft tissue and for marrow, it gives the best of the details. For the marrow details, for the soft tissues, for the thecal sac, for the coursing nerve roots. But one limitation in post-op spines is extensive susceptibility artifacts, and that is because of the implants that are put into. So for those scenarios, these are the newer sequences which are available by the name of Maverick, WAP, CMAC, depending upon whether it is GE or Siemens. So what they do is they significantly reduce the artifacts and make it more image friendly. CT myelography. Okay, so you just do a lumbar puncture, you inject the contrast, right? And anything Iohexol will do, and then you image. You put the patient in a dependent position so that the contrast moves along the thecal sac spaces. And depending upon the area of your interest, if it is lower part, you make it like in a lower part dependent, lumbosacral dependent position. If you want it in the above segments like cervical dorsal, you reverse the patient, head is relatively down so that it gets distributed. So it's a way of seeing the thecal sac है ना, and the associated nerve roots, the traversing nerve roots. So it's really good in those senses. Then nuclear imaging, right? Nuclear imaging is also deployed at times as and when needed. So something like this might come up when you are reporting an X-ray. So this is like a stability construct which has been done for a patient with scoliosis, right? So when you see these are the screws. Obviously, they look like screws, and by the name also they are screws. These are the screws, and these are the rods. So the rods are basically used for stabilization of the posterior elements. And through these rods are passed the screws, which you look over here, mostly transpedicular in nature for the lower lumbar spine and the dorsal spine as well. And they move into the vertebral body. Also, what in addition you are able to appreciate is this. The posterior elements have started showing ossification. Osseous changes are there, which suggest that there is fusion which is going on and which is actually the desired outcome of the stability construct. This is done for the scoliosis for the curve correction. Something like this when you do an MRI. So this is like a T1 weighted image. This is a stir sequence. This is without Maverick. And when you use a Maverick sequence, this is what happens. There has been significant change in the associated susceptibility artifacts, which are able to appreciate over here. But then with the Maverick sequence, you are significantly able to reduce them. The image looks more better. The image looks more friendly. Coming to this, so the implants, the hardware that they use could be of different materials. Depending upon that, this is something which is stainless steel. So the stainless steel implants or the hardware, they have a tendency to give out significant artifacts. These are streak artifacts. Something which is very dense tends to cause the shadowing of alternative hyper and hypo dense line-like changes. And this is like a stainless steel implant. On the contrary, this is a titanium implant. So titanium, tantalum, these are the ones which cause lesser streak artifacts, right? Relatively more image friendly as compared to the stainless steel artifacts. But yes, they are more expensive. So the tendency of encountering them, the incidence of encountering them might be less. So what could be done when you reduce the artifact? Some machines have a already set pattern. Whenever you do, there is an artifact CT, artifact setting that they activate or they choose, and it automatically does this, right? So if it doesn't have, then you can modulate, you can change, like increase the KVP and the MAS. You can reduce the bandwidth, acquire thinner slices, and for visualization, use the thicker slices. Then you have to narrow down the collimation and you have to extend the CT scale. So these are the basic steps when you have to reduce the streak-like artifacts. So something that you can do, not just for the spine, but for anywhere in the body. This is something that needs to be done. MRI has also similar artifacts that we have discussed. Something that could be done to reduce this artifacts is encoding direction, that is the phase direction should be parallel to the hardware's log axis. That is one thing. Then using fast spin echo, turbo spin echo, again reduces the artifacts. Using stir reduces the artifacts as compared to the rest of the fat suppression techniques. Increasing the bandwidth, increasing the voxel size, and reducing the field strength. So if you're having an option of 3 Tesla versus 1.5 Tesla, you can go for a 1.5 Tesla to reduce the susceptibility artifacts. Coming to the nuclear imaging. So nuclear imaging is something that comes into role when CT and MRI have not been very conclusive. CT maybe because of the extensive street-like artifacts, MRI maybe because of the extensive susceptibility artifacts. So then this comes for our help, right? Something like this, a gallium scan, and along with technetium-99, they are good for localization of infective etiologies, right? Again, SPECT-CT for infective etiologies, for degenerative changes, for osteophytes, especially for the facetal joints, this does well. But otherwise, very commonly used is the FDG PET. FDG PET does very good in terms of localization of inflammation as well as infective pathologies. Something like this, a spondylodiscitis might be active, might show a good uptake on PET CT. Something like this, residual collection. So yes, when in doubt, maybe then PET CT might be of significant help. So the operative procedures are varied and they are numerous, and so are the hardwares, right? Something that we should know are these, which are something that you can ask also, go back and look in the surgical descriptions also, surgical files also. This discectomy, as we know, is removal of the disc, either completely or maybe a partial discectomy where the only the herniating part is removed. Then we have laminotomy, that is like a minimally invasive. Over the top decompression is when you take an excess from one side and remove the lamina on the opposite side. So then it is known as over the top decompression, right? Laminectomy is removal of the lamina, unilateral, bilateral, and it is most of the times, I mean 100% of the times rather, it is associated with flavectomy, removal of the ligamentum flavum. Facetectomy could be partial, could be complete. Complete is significantly associated with instability. So what they try to do is remove the facet when it is having significant facetal joint arthropathy, significant osteophytes are associated, causing significant foraminal compression, maybe lateral recess compression, maybe posterior lateral compression. Then they start seeking for removal of the facet and they try and not to remove more than 50% because it increases the chances of instability. Then laminoplasty is something when they do laminotomy or laminectomy, they try to limit themselves from the associated instability. So either they mostly use some wires to actually close that open space, mostly associated with laminectomy if they have to. Pediculectomy, removing the pedicle. And what is corpectomy? Anybody? The name is not very suggestive, and that's why I'm asking. What is corpectomy? Come on, guys. Yes, so vertebral body removal is corpectomy, right? Which one are you asking? Last point ones, which one? Tell me, Fatafat, say which one? Over the top. Okay. So over the top is nothing but removing the superior or the inferior aspect of the lamina of the contralateral side when you're taking an approach from one lateral aspect. So if you're taking a right-sided approach, then you're able to remove the right lamina along its superior and inferior aspect, as well as removing the other side from the same approach rather than approaching from the other side. So it's like over the top decompression. All right. So this is what a laminotomy looks like. Laminotomy is not complete absence of it, right? The lamina, the inferior aspect of the upper body's lamina and the superior aspect of the lower body's lamina is resected, right? And this resection is done so that to create space to cause that decompression. So this is like a laminotomy, not significantly associated with instability. Thus, fixation is not really needed in this one. And sometimes it is mostly done to first decompress the structures, the neural structures, and the second one is to take an access to the disc removal, right? So it gives you a slightly better access. If you have to take an access from this side, obviously not that good, so it gives you a better access. So this is laminotomy, right? This part is removed and then this part is removed, so thus creating a more space, causing decompression. Something like this. When you are imaging, it might look something like this. Slightly irregular. The lamina is not very well visualized over this aspect. some irregularities, some hypointensity is what you are able to appreciate. So this is what laminotomy looks like. You can, again, if the information has not been provided, you can go back and ask and look at the contralateral lamina. This is something that it should have looked like this. The inferior aspect must be there, right? If it is the lower vertebrae, then inferior aspect must be there. So only the superior aspect will show like this. A hemilaminectomy will show complete absence of it, whereas only a portion will not be seen in cases of laminotomy. So something like this, again, a laminotomy. So done for this, the disc is herniating, the disc is showing extrusion and taken excess from the right side with the laminotomy feature. Some irregularity is there, and the herniated disc is removed. So this is laminotomy with discectomy, right? The disc is removed through the axis from the right lamina. So these are the differences, what I have told you. Laminotomy is this resection of a part of the lamina in order to widen up the space and decompress the structures. Hemilaminectomy is complete removal. The upper aspect, the mid aspect, the lower aspect, entire lamina, unilateral lamina is removed. That is hemi, and laminectomy is like a complete removal of the lamina along with the spinous process. So something like this. This is what a laminectomy looks like. On CT, you are able to see that one part of it is not seen. Sometimes some parts are seen, like this part of the lamina is seen, this part. Sometimes some people prefer to call it as like partial laminectomy, but yeah, it is a variant of laminectomy, right? And not a complete one. Since you're able to see the right lamina, you are able to see the spinous process. And this is how it might look on MRI. An area of irregularity, area of non-visualization of the bony outline. And it might be associated with unilateral facetectomy. That is, the ipsilateral one-sided facet has been removed along with the laminectomy. So what laminectomy does is it gives you one, relief, decompression from the canal stenosis, the central stenosis, and second is it gives you a greater exposure, greater area to actually intervene and remove the disc. So when the herniating discs are big, they appear to be more big in size, one, or they appear to be dislocating superiorly or inferiorly. That means the extent of the extrusion is higher inferiorly or superiorly, or might be that the extruded disc is not exactly located over here and slightly on the above aspect. So for this axis, it will try to remove that entirely so that it can angulate itself and go above and remove the sequestered disc. So in these cases, a wider approach is being offered by hemilaminectomy. All right. So there are two kinds of surgeries which are currently going on. One is minimally invasive surgery, and the other one is traditional open surgery. What they try to do is this one, minimally invasive surgery. Only few incisions are being given, very similar to what you call is that laparoscopically. And the other one is like completely opening it up. Obviously, this has got lower mobility, early mobility, lesser morbidity. So this has got a better response. There are different approaches from where you want to approach the spine, right? In cervical spine, the approach is both anterior and posterior, right? Very equivocally, even I would say anterior is more common than posterior. The posterior approach is more common in cases of trauma or atlantoaxial instability or maybe platybasia, which involves the occiput fixation along with C1, C2, C3. So for those, posterior approach is more common. Otherwise, for degenerative changes, anterior approach is more common. For dorsal spine, posterior approach is more common, and lumbar spine has been explored with all these approaches: anterior, posterior, lateral. Something that we commonly see is a posterior approach, right? And it goes by the name of these. These are all the names that you encounter. That is anterior lumbar interbody fusion. Interbody means in between the two vertebral bodies. Anterior, why anterior? Because you're approaching interiorly. You're approaching from the lower aspect of the abdomen. So more particularly suitable for L5S1 approaches where you can actually retract the vessels, retract the lower abdominal vessels, the aorta has already bifurcated, the IVC is yet to form. And at those spaces, it is easier to retract. So this is particularly for more convenient for L5S1 approach. Then lateral interbody fusion again. Lateral interbody fusion is through the psoas that I'll tell you. Posterior is something that we commonly see, like the patient is prone, you open, you slowly dissect the layers and you reach the spinous process. This involves removal of the supraspinous and the interspinous processes also, interspinous ligaments also. Then we have a transforaminal approach, again, a kind of the lateral approach where you're approaching through the neural foramina, and intertransverse space, again, a lateral approach where you are traversing through the transverse in between the two transverse processes. The idea or the aim behind all of these approaches is to go and cause the fusion. Put your hardware in and cause the fixation. So fixation along with the hardware is all your entire idea. And to remove what you want to remove, if it is a disc, if it is a facet, so that's if it is a lamina. So hardwares that are used. Plate with a screw fixation is something that you very commonly encounter in cases of cervical spine, right? This is something that I told you. And the most common approach is obviously anterior approach. So anterior approach cervical spine and plate with screw fixation. Plate is something like this, and screws pass through the plate into the vertebral bodies, right? And this is very commonly done for cervical spine and degenerative diseases, degenerative changes. When you are trying to fix the posterior elements or the lateral mass or the posterior elements, then obviously posterior approach is something which is done. As I told you, in cases of platybasia, is something that a posterior approach works well. Also, in cases of trauma, depending upon which part of the body is affected, if the vertebral body is affected, then obviously anterior approach. If posterior elements are affected, then a posterior approach, and sometimes a combined approach is guaranteed or needed. Something like this. Again, when you see, so the hardware is a plate, that is a plate, and the screw is extending from this plate into the vertebral body. When you see the screws like this, they should be horizontal. They should be parallel to the vertebral body, right? Should not extend beyond the posterior cortex. The posterior cortex should be intact. Anything which is more tangentially associated with the vertebral body has a chance to be displaced, and maybe subsidence of it might be associated in the later stages. So, plate and screws. Also, what you're able to appreciate in this one is that bone formation has started. And that's what they want. They want stability. And that's why they have done this. So what they do is they do discectomy, they remove the disc, they put plate and screw. And they rub their edges, make them irregular so that the osseous formation starts. So if this is beyond 9 months, then it is abnormal because it has not a complete arthrodesis has not been achieved. If it is like less than 6 to 9 months, then it is fine. The process might be going on. So this is something which you commonly see in the lumbar region. That is a rod with the transpedicular screw. Beautiful, 2 rods, screws, mostly 4 screws in this particular situation, right, left, right, left. So this is a rod with transpedicular screw. Again, when you see the screw is oriented horizontally, or a better way to say is parallelly aligned to the end plate, right? It is not extending beyond the anterior cortex. Look at the anterior cortex. The anterior cortex is normal. So should not be extending beyond, invading or extending beyond the anterior cortex. Should not be either medialized, should not be either lateralized, right? So it should be coursing through the pedicular margins. The pedicular margins, and should not come medially or laterally. In those scenarios, it is displaced, right? And this approach is pretty common from dorsal to lumbar. So very commonly, you will see this approach in clinical practice. So this is what I've already told you, the planes and the parallel scenario. So you need to look at this, and how well it is oriented should not be tangential, even in the cervical vertebrae, even in the lumbar or dorsal. The concept remains the same. And that's the posterior aspect, that's how they try to fix it. And it mostly is accompanied by laminectomy, right? So laminectomy with discectomy, they try to remove the disc. They might remove the facet as well if at all needed. And then these rods with the passage of these screws, which are going through the pedicle into the vertebral body. Coming to next one, again in a very similar pattern, as you see the rods, the associated screws, So this is like a lumbosacral fixation, and this stability construct has been done to correct the scoliosis. So when you see this, that there is associated osseous formation close to the posterolateral aspects of the vertebral body. And in the midline, what you're able to appreciate is a complete laminectomy, non-visualization of the Spanish processes of these vertebrae, and new osseous bone formation, which is like a good sign, a positive sign of this fixation. That is, we are close to the aim of fixating with a construct. So this all collectively is known as a stability construct, right? Immediate stability, early mobility is something that you achieve with the stability construct, which is being done by PLIF, these transpedicular screws, and that is why it is one of the most commonly done. And this works well for both scoliosis and spondylolisthesis.